I'm waiting. Hello, everyone, and welcome. We're just waiting to give people some time to enter the webinar. Hello and welcome. Thank you for joining our webinar, Implementing a Complex Care Shelter, Opportunities and Lessons Learned. My name is Yolanda Stevens. My pronouns are she, her, and hers. I will be your host and moderator for this webinar brought to you by the National Alliance to End Homelessness. There, I have the pleasure of serving as a program and policy analyst focused on older adults and healthcare. We expect a large number of attendees, so all attendees will be in listen-only mode. We are so grateful that many of you have an interest in this important topic and would love to know who's in our audience. So please feel free, as I see some of you are doing, entering your name and the organization that you represent in the chat. And also joining me is Malik Rivers, who will help with any technical issues you may have. So please use the chat for any technical issues and reserve the Q&A for questions, which the presenters will be happy to answer at the end of the webinar. And just a reminder that this webinar is being recorded and the slides will be posted on the Alliance's website at the end of the week. This is an especially important topic for me since so many older adults have complex healthcare needs, functional impairments, including limitations with activities of daily living like bathing and toileting, and instrumental activities of daily living like medication administration, as well as some of those social issues like depression and anxiety and cognitive impairment, all of which can be challenging to support in a traditional shelter setting. Additionally, there are few resources for shelter options to support these diverse needs. And despite this, many of you are working to meet the needs of older adults and adults with disabilities who are seeking services from your respective programs. So when I read this article that spoke about the work being done in Anchorage, I contacted Dakota Arm, who is the Healthcare Integration Director for Anchorage Coalition to End Homelessness, and David Rittenberg, who is the Senior Director of Adult Homeless Services for Catholic Social Services, excuse me. And they quickly became two of my favorite people because I heard the passion, I heard the commitment to those that they are serving in their community. And it is my hope, and actually I doubt that you will not quickly feel the same way that I do. We hope that you will feel similarly, and you will have gained some insight and takeaways to inform you as you modify your crisis response systems, if necessary, to address the needs of those with complex care needs. To ground this conversation, they will share a little bit about the role of healthcare and homelessness. And you will also be able to hear throughout this process and throughout the conversation with them, you'll be able to hear what it meant, the steps that they took. And I think prior to us getting really into that conversation, I want to be able to really provide some information as it relates to housekeeping. I'm having just a little difficulty advancing the slides. Okay, so some of this you've already done. You know the slides are posted. Here is pictures of our presenters today for you. And then the agenda, as I started sharing with you earlier, was really to have that connection discussion around healthcare and homelessness, to really ground the conversation. We all know that homelessness and ill health have been locked in this ongoing cycle of cause and effect, where poor health can make someone at risk of becoming homelessness, especially when you think about being able to take care of those medical expenses. And we also know that homelessness puts an individual at risk for increased poor health. We also know that homelessness complicates efforts to treat illnesses and injuries. Unfortunately, you've probably seen that some healthcare organizations have recognized the link between housing and health and are addressing housing insecurity as a pathway to improve health outcomes and reduce costs. We'll hear a little bit more about the role of healthcare systems. You'll hear some information about the overview of the pilot that was implemented, which kind of paints a picture of the landscape that Dakota and David were navigating as they addressed the needs that they saw in their communities. They'll talk a little bit about the role of partnerships and community building, and a brief overview of complex care, what it is and what it isn't, and then share some programmatic outcomes. All of this will be followed by question and answer. So now, without further ado, I will turn this over to Dakota and David.
Hello, everybody. Thank you so much for joining us today. My name is Dakota Orm. As Yolanda mentioned, I'm the Healthcare Integration Director for the Anchorage Coalition to End Homelessness, which is Anchorage, Alaska's HUD-designated continuum of care. So we are responsible for the design and implementation of our homeless prevention and response system in Anchorage. So to kind of lay the ground and answer the question of what is healthcare and homelessness is to look at the impact that houselessness has on your health and the intersection and relationship that the healthcare system and homelessness response system have. So your health status is heavily impacted by your social drivers of health, previously known as social determinants of health. And social drivers of health are the conditions under which people are born, where we grow up, where we work and live, that have a direct impact on a person's health. And these drivers affect many different health risks and also different health outcomes that often lead to different health disparities. And this includes your housing status. Your housing status has a direct impact on a person's health, and these drivers affect many different risks, and it affects your ability to gain access to health care. And a stable home provides the ability to rest if you're feeling unwell and isolate yourself if you're feeling symptomatic, and also provides a place to recuperate if you're in need of different medical procedures. And you also see complex high medical needs in seniors and people with disabilities, two populations who are often on low and fixed incomes. And when life events occur that affect your finances, like a medical event, you're very likely to lose your housing. When you lose that safety and that stability of a home, other medical issues can arise, including unmet behavioral health needs that were mitigated by someone's housing status. Access to food is also a social driver of health. It costs more to make sure you're getting the right foods. It requires having access to a kitchen to make those foods for yourself and your family. So what is essential to someone's health? Housing. Housing is the #1 prescription. And when you are experiencing homelessness, you have worsening health outcomes. And for this already vulnerable population, you often have serious and complex health challenges, and certain health conditions are more common and made worse. Along with that, when you are experiencing homelessness, you are 7 times more likely to lack health insurance. And so even the life expectancy of people experiencing homelessness is significantly less than the housed population. And so ensuring access to quality health care must be a part of the plan to address and end homelessness. And healthcare can be effective when integrated with someone's housing plan. And then in the healthcare setting, a person's housing status can cause a lot of stigma and misconceptions, even among trained medical providers. And so for an individual experiencing homelessness, there is a feeling of safety when they enter the healthcare environment, but the judgment they can sometimes experience can hinder their ability to really express what their needs are. And so both systems will often see the same individual, sometimes over the course of years, and neither knew what information or work in case management hasn't been done in either system because they weren't communicating. And healthcare as a system can play a critical role in ending homelessness for an individual and for a community. They have more knowledge on a person's well-being and their health conditions, and can play an essential role in coordinating a person's care and ensuring they obtain safe housing. And so we'll go to the next slide and see how we can get these two systems talking. I don't know if Yolanda, if you can go to the next slide. I'm still having some trouble.
Yeah, I'm still having trouble with the slides.
Oh, no worries. So we'll just begin talking and the slides will catch up. So Anchorage began participating in a national pilot with 4 other communities to explore the question, how can healthcare as a system and as a service really be a catalyst towards ending chronic homelessness? And chronic homelessness, as a lot of us know, is someone who experiences homelessness for more than a year, or at least 4 different bouts of homelessness within 3 years that add up to 12 months or more, and they have a disability. So we were chosen for this pilot in part due to the quality data we were collecting and the healthcare and homelessness partnership that Catholic Social Services spearheaded, which we'll hear more about from David in a moment. And our goal in this pilot with our partners is to reduce chronic homelessness while also building racially equitable systems. And we do this through piloting new projects using an improvement model, the PDSA, which is Plan, Do, Study, Act, where we do small tests of change and evaluate throughout to ensure that the improvements we are making are working and that they're working for everyone. And in our community, that means not just working for those who are white and not just working for those who are non-disabled. And so we'll go to the next slide and we'll hear from David about what we were doing before the pilot with our healthcare systems.
Hello, as we mentioned, my name is David Rittenberg. I'm the Senior Director of Adult Homeless Services for Catholic Social Services. Most of my experience has been in shelter operation. And with that, we had seen a very large increase in our population over 65 in the years leading up to this more localized healthcare and homelessness partnership that CSS entered into. But we saw about a 240% increase in our 240% increase in our over 65 population between 2005 and 2015. With that, we were seeing a much higher occurrence of age-related health types of issues, a lot of people that were struggling to meet their daily basic needs. And then with that, just sort of the environment that we had in how our HPR, our homeless prevention response system was set up, we had a high concentration of individuals in one location. And so in an effort to really bake in healthcare to our shelter services, get better health outcomes for people, and have a reduction in emergency service calls, Catholic Social Services entered into a more localized healthcare and homelessness partnership with some local healthcare providers and our 3 major hospitals that sit in Anchorage, and that would be Providence, Alaska, Alaska Native Health Center, and Anchorage, Alaska Regional Hospital, excuse me. And so with that, we sort of created 3 programs within the Brother Francis shelter, which was the largest low barrier emergency shelter for people experiencing homelessness in Anchorage. One was a clinic. And so we brought one of our healthcare providers in to staff a clinic that had historically been a volunteer-run clinic, which we were very thankful for, but it was Dr. Jones one day and Dr. Smith another day, and there wasn't that sort of connection from visit to visit to visit. And so having a healthcare provider come in and be able to provide that consistent service, and then more importantly, a consistent face. So someone that someone can build a relationship with to help get their healthcare needs met. We also opened up a 10-bed medical respite program within our shelter. We have a sort of a separate wing in back for people being discharged from one of the hospitals where they just need a little bit of rest and just a little bit of time to recuperate before they can sort of get back on their feet. And then with that program, there's medical coordination, so coordination to follow-up appointments, and making sure people are getting their needs met there. And then sort of the third piece of that pilot was non-emergency medical transportation, which CSS provides through donation dollars. And if someone has a follow-up appointment from the medical respite program, or they go into the clinic and they need to see a specialist, or it's something that can't be addressed in the clinic. Lots of stuff can be done in the clinic and just really, really wonderful. But if someone needs a specialist, or they need to go to the emergency department, but it's not a lights and sirens emergency, CSS will pay for that transportation to and from through taxi vouchers rather than an ambulance. And so those 3 pieces of the partnership there are clinic, the medical respite program, and our non-emergency medical transportation really sort of laid the groundwork for what was to come next.
So since the pilot began in about 2021, we have made new partnerships while actively measuring for improvements and success, and we've created transferable learning. We have a dynamic project portfolio to share with both our community and the communities across the nation. And so along with the assistance of the creation of complex care and continued connections to the facility, the projects include specialized case conferencing for those who are medically fragile with a pathway to apply for home and community-based waivers, and a liaison between different hospitals and our homelessness prevention response system to assist people who are being discharged from the inpatient setting so that they can navigate the system for a safe discharge and hopefully leading to fewer readmissions. And the aim is really continuous improvement throughout the system for better outcomes for every individual. And through this pilot and the creation of a complex care facility, we've made the larger commitment as a community to work towards establishing healthcare at every level of intervention in our system. Whether you are camping outside or staying in your car, staying at one of our shelters, we aim to improve access and service delivery for every individual, which is also represented in our community plan on homelessness, Anchored Home, and truly integrating healthcare as part of the response to this community epidemic. As homelessness is a public health crisis that really requires a public health response.
And so now I'll sort of talk a little bit about the COVID-19 impact on the HPRS, which also, was very challenging in many ways, but also created some opportunities. So as I'd mentioned, Anchorage largely had a localized area where most people experiencing homelessness would come down to access services. There was about 400 beds in one location. And then when this highly communicable respiratory disease arrived, the community realized that that probably wasn't the best way to be sheltering people in order to mitigate impacts of COVID-19. And so the community worked together to expand emergency shelter beds, and the municipality opened up a very large, it was an old hockey arena that is pictured here, to be the primary place where people could be sheltered in a more socially distant area. We also worked with landlords and tenants and created some financial assistance programs through ARPA dollars and some of those other, COVID-19 funds that were out in the community. So to keep people into housing, keep people in housing and move more people into independent housing using those funds. And then also, in addition to the very large Sullivan Arena shelter that had about 400 or so beds in it, opened up quite a few non-congregate locations in shelter in hotels that were not being used for tourism during that time. So a little bit of economic stimulus for the hotels, and also providing non-congregate shelter. And I don't know, there's probably 5 or 6 of them throughout town. And then also setting up a robust testing and quarantine and isolation, and eventually vaccination programs to make sure that those resources are available to shelter providers and the individuals that were staying in shelter. So with that, most of the individuals moved out of Brother Francis shelter. We were historically serving 240 individuals, but obviously could not do that in a socially distanced way. And work with our clinic, those relationships that I was talking about a little bit earlier about, having a consistent provider in clinic, really got us to a very high vaccination rate. When a vaccination did finally come out after 2 clinics, we got up to about an 86% vaccination rate, which we're pretty proud of. But we can pop over the next slide. So just a little bit of background about Brother Francis Shelter that can sort of lay the groundwork for the change that we made. So we originally opened up in 1983 and has served as the primary shelter for Anchorage up until the pandemic. We were a 240-bed night-by-night shelter, provided a lot of basic needs services, laundry, case management, clothing, meals, storage. We had that clinic, those types of services, and then that already built up healthcare and homelessness partnership. Another just sort of couple of things just physically about the building is that we're 1 story. And so people did not have to need to go up and down stairs to be able to access the facility. We're one of the few shelters I have visited that was specifically built to be a shelter. Most places that I've had the pleasure of visiting is a converted other building. And so, we were originally set up with wide doorways and handicapped accessible showers and, those types of things. And so when the large low barrier walk-in shelter became the Sullivan Arena, as a community, we realized that a lot of individuals that might have these complex medical conditions or use a wheelchair or walker, cane or crutch, or might have asthma or COPD or vertigo or like something like that, would have a lot of difficulty navigating the Sullivan Arena because you had to go up and down a lot of stairs to be able to get around that facility. Beds were down on what used to be the ice service. Meals are up in the mezzanine where snack bars and stuff was, and it was just a very large facility to get around. And so recognizing that Brother Francis Shelter moved into reducing our capacity. And so we reduced to about 75 beds, got everyone 6 feet apart, and then started serving people that had complex medical conditions or those access challenges. It was if someone wasn't able to navigate the stairs at the Sullivan Arena, we would take them at the Brother Francis Shelter. One, just because of that physical makeup of the building, and then two, we already had, a lot of those medical resources built into the shelter that many of those individuals might need, such as the clinic or that medical transportation for appointments, or those types of things. So go ahead and go to the next slide.
So it is really essential that for a community to work towards ending homelessness for everyone, got to understand that it'll take all aspects and all industries, and really cross-sector collaboration is key for understanding what the need is, where the need is highest, and also coming up with creative solutions for our most vulnerable populations. So during the COVID-19 response that we had for our unhoused community, a task force was assembled to discuss how to transition people out of these mass care shelters. We recognized the need for smaller, more spread out shelters that were catered towards specific populations. And standing up a shelter for people who are medically fragile is the first to come online due to that experience and what we did at Brother Francis Shelter. And so we came together from the nonprofit side, the private sector and building owners, consultants and government to find and fill the gap in our services and better understand how to meet that need and truly make homelessness rare, brief, and one time for everyone, and not just those who are most able. And having different members of the community at the table, we were able to get creative and really ask important questions, and from a collective effort, analyze what the challenges were and have a different number of options before us. It took many hours of meetings and discovering solutions that sounded perfect, but on closer inspection did not work for our community. And a critical step to this, to really understanding this complex challenge, was to understand the data. So it's critical in a community to have quality data on special populations to ensure that we're providing the right kind of assistance and really understanding what the gaps are in the services that we're providing. And through looking at and understanding the data that we did have in our Homeless Management Information System, HMIS, we were able to see that over 200 people in our system had 3 or more co-occurring disabilities. And their needs were just not being well met at a regular low barrier congregate shelter, as Dave described, and their medical fragility was acting as a barrier to access safe and sustainable housing. And this also steered us towards creating eligibility criteria and prioritization of those who would be referred to the complex care facility. And that while, yes, we were opening a shelter, we needed even more shelter space. So it is really only through our collective effort that we can help those in need and create a better community and really a better future for everybody. We'll go to the next slide.
Yeah, so complex care, as someone that had has worked in shelter for quite a while, it was really exciting to be able to work on opening up something that was innovative and just a really big need for the community. We would have a lot of people coming into shelter that staff just were not well equipped to be able to serve. Or the building just was not, the resources that we have just weren't well set up for serving this special population. And so, as Dakota had mentioned, as the community was looking at how to sort of demobilize some of these COVID-19 programs that came online as a result of the pandemic, we had the experience of having 400 beds in one location down on 3rd Avenue where the Brother Francis Shelter is, and then 400, 500 some odd beds at the Sullivan Arena. And the community was realizing that trying to concentrate services all in one location was very difficult to for staff, for the people that were staying there, and then also for the community impact. And so as we were sort of deciding how to sort of come out of this, the community wanted to see multiple smaller programs that were more right-sized for the facility, for the neighborhood, and be able to better serve, people's individual needs. And so without knowing it, we piloted the complex care shelter at Brother Francis Shelter for 2 years during the pandemic. And as we were starting to sort of come out of some of our pandemic posture, an opportunity presented itself that a hotel came up for sale, and we just had the right mix of some public dollars coming online, some COVID-19 dollars that were available, and some philanthropy that was motivated and ready to really kind of make a change in the community. And so, from really inception to opening was about 6 or 7 months. We really started talking about this in maybe December, and we opened up on June 6th of this past summer. So you can see that top picture there is just sort of a picture of the hotel. And then it's a former sockeye inn. And for those of you not from Alaska, sockeye is a type of salmon, very big up here. And one of the typical single rooms down at the bottom there. So when we initially opened up, we filled it with about the 75 people that had been staying at Brother Francis Shelter. We had the opportunity to close Brother Francis Shelter for a week for the first time in 20 some odd years, and able to do a little bit of deferred maintenance, get some paint up on the walls, just some stuff that's been difficult, dangerous, or disruptive to do when it's full of people. Move those individuals over to complex care, and then reopened Brother Francis Shelter for 120 beds of low barrier shelter with a couple of tweaks. And so complex care is made up of 83 beds, single and double occupancy rooms, a lot of the similar basic needs services that you would find at Brother Francis Shelter or any other shelter, laundry, storage, case management. We provide free meals per day there. We provide some transportation, and 24-hour staff, those types of things. You can go to the next slide. And so just a little bit about the operations of the program. We're not walk-up services at Complex Care. It's a referral-based program. So if someone were to present at another shelter that that shelter is not able to really meet that person's needs, as well as they would like, they can make a referral to the complex care program. That's just an online referral program, referral form. And we also take referrals from hospitals, healthcare providers, outreach workers. It's a pretty broad base of referral sources. And then depending on how that referral is completed, and the questions that are answered, if someone's sheltered or unsheltered, if they have certain pre-existing conditions, if they have mobility challenges, their age, if they're pregnant, those types of things will place them on a sort of a prioritization list. And so it's not necessarily first come, first serve. It's based on, those prioritization points that someone gets when the referral is made. And then, people go onto a wait list, and then are entered into the shelter, once a bed becomes available. As I mentioned, a lot of those basic needs services, 24-hour staff across 3 floors, showers, laundry, meals, transportation. We do quite a bit of social and emotional well-being activities. We've done field trips to the Alaska Native Heritage Center, the museum. We do karaoke every Friday night. We do bingo during the week. We have some volunteers coming in to do art. And so making sure that it is more than just a place where people can be, but there's, we're building some community there. And another, really important piece of this is we were sort of opening up a new program. in the midst of all of this was just making sure that we got the community and the neighborhood involved, making sure that we're engaging with them, going to community councils, inviting them down for tours into the space. And we have our staff in their vests sort of walking the neighborhood as well, and making sure that if anyone's wandering away, we're making sure to bring them back. So in addition to some of those sort of operational pieces, we also have a team of specialized case managers there that have gained a specialized sort of expertise in the types of services that the individuals staying at complex care are going to most benefit from. So all of our case managers are SOAR trained. They have some knowledge about getting people connected to Medicare or Medicaid or private insurance or the VA. So making sure that people can get a healthcare payer and getting connected to primary care, getting someone connected to transportation resources. Like we have a program up here called Anchorage for people that are elderly or disabled to get free transportation. There's a whole different sphere of services that someone that might be a little bit older or might have access challenges or complex medical conditions are going to need to be able to live independently. And so the goal of the case managers there is to, one, if someone is not already on our coordinated entry system, get them into that coordinated entry system, which is our sort of our housing prioritization list. And then while we're sort of waiting for that individual's time to come up on coordinated entry, making sure we're working to get those supports in place that they're going to need to be able to maintain housing long term. And so whether that is having in-home care come in a couple of times a week, or those transportation resources, or making sure someone getting connected to primary care and getting their prescriptions and all of those things that they might need. So when they are ready, when housing does become available to them, they're able to move right in and have those supports in place. And so I think we can pop over to the next slide. And so we've been operating for about 10 months or so, 10 and a half months. I ran this report last Friday. So these numbers are sort of hot off the press here, but we've taken about 600 referrals, and we've served about 201 unduplicated individuals in about 10 months. And so some of those 600 referrals are duplicated. If someone touches multiple points, say they see an outreach team and a shelter worker and a hospital, we might get 3 referrals from the same person. But we've served about 200 and a little over 200 unduplicated individuals in the first 10 and a half months. Over half of our referrals come from shelter partners, and whether that's going to be we have the Sullivan Arena that I mentioned before, or we also refer a lot of people from Brother Francis Shelter, and we have a couple of other shelter programs or outreach workers that will make referrals as well. And we're finding that due to, we usually have about 30 to 40 people on the wait list, that there's kind of a sweet spot in the prioritization that's really based on acuity, that, we're finding that if people don't have at least 4 prioritization points, then they're going to sit on the wait list much longer than, say, someone that has 6 or 7, or I think our max is 8 prioritization points. Understanding we've only been open for about 10 and a half months, and we're gathering data now and are going to continue to look at this and make improvements and adjustments and refine it as time goes by. But of the people that have been referred, about 70% of referrals make it onto that prioritization list. Some of the reasons why someone might not make it onto the prioritization list would be things like, 1, we got a referral for someone that is not homeless. 2, their medical needs are really much higher than what we're able to serve at complex care. So, keep in mind that this is still emergency shelter. We do need people to mostly be able to do their activities of daily living independently, The staff at Complex Care do get a little bit of extra training, for supports and lifts. So if someone were to say fall out of their bed or fall out of their wheelchair or something like that, that we are able to safely sort of pick them back up and help them out. But staff is not trained, and the program is not intended to be doing transfers for somebody every day, or providing those activities of daily living. And so sometimes we do get referrals for individuals that are just a higher level of care than we're able to provide. And so, since we've been open, we've moved 27 people to temporary or permanent housing situations. So whether that's their own independent housing or living with family or friends or that reconnection, or moving into, say, permanent supportive housing or that type of thing. 17 individuals went to a non-psychiatric hospital. So their complex medical conditions sort of flared up and where they needed more hospital level care. We've had 4 people move to long-term care or assisted living facility or a nursing home or that type of thing. And 1 person has moved out to a treatment facility. Our average length of stay has been about 17 days. Typically, people spend about 2 weeks on the prioritization, maybe a little bit more, depending on those prioritization points. But on average, it's about 2.5 weeks that someone will be on the wait list before coming into complex care. And then I think that about does it. We can pop over to the next slide.
Thank you again for everybody that's joining us today and learning about our community's response to help our most vulnerable. And we wanted to leave an ample amount of time for questions, as we know that this is a very interesting topic and there aren't a lot of shelters like this across our nation. And this is kind of newer, and we're piloting it as we're not even a year under our belt yet. And so we welcome any questions. We're excited to see what questions you've already put in the chat. If you haven't already, it's the Q&A chat down below. And we're excited to have an interesting conversation.
Okay, well, thank you again, Dakota and David, for sharing the information about how you went about implementing a complex care shelter. There are quite a few questions. The first question from Deanna asked, were there nurses located in the medical respite? And what about therapists?
Hi, I think I can answer that. So at Brother Francis Shelter and Medical Respite Program, we don't provide any medical services on site per se. So we don't have nurses, but we provide that environment in which people can heal, and then that sort of coordination, making sure someone has the knowledge and the resources they need to follow up on whatever directions they got from the hospital upon discharge. So it sits within the shelter. So no nurses, to answer the question.
Okay. There was another question asked, is the shelter still at reduced capacity?
So we learned a lot by operating a shelter at our max fire code. So our fire code was 240, and we tried to serve 240 individuals. We found through that experience that just because your fire code is 240, that doesn't mean that's your optimal programming level. And so we reduced to about 75 beds during the pandemic, and we've increased back up to 120. And we feel that is really kind of the sweet spot, providing the most shelter beds possible, while also giving people a little bit of space and having a better staffing ratio and those types of things. Really think 120 is a much better fit for that building.
Mm-hmm. Thanks. Deborah is asking, for the single room, what is the average square foot?
Oh, gee, I don't know off the top of my head. It's a typical motel room. Not huge, but not tiny.
Mm-hmm, mm-hmm. And then the question is, well, do you have a waiting list, and has it completely fulfilled the need? This is a question from Deanna.
So we do have a wait list. Typically, we have about 40 people on the wait list at any given time. I would say that we have taken a bite out of the need, but I wouldn't say that we've completely met the need at all. I think one of the big challenges that we have is there's not a lot of empty housing stock in Anchorage. And so, that's really kind of one of the big bottlenecks that we have is once people are in programs and getting those supports, it's where do people go after that? And so I think as a community, we need to do some work on that. But Dakota, I'm interested in your response here.
Yeah. As Dave mentioned, the shelter opened with 83 beds. And when we were kind of looking at all of the data, when we were originally kind of building out what this could look like, we found that over 200 people in our HMIS system had 3 co-occurring disabilities, and we're also experiencing chronic homelessness. And so while, yes, we did kind of take a bite out of that, we still had over 100 people where their needs just weren't being met in a low barrier shelter. And also, as Dave mentioned, it's not an assisted living facility. And so sometimes somebody's needs can be a lot higher than these services that are being offered at the facility. So we still have kind of this gap in our system, but it's important to kind of really look at those gaps, recognize them, and continue to work to try and improve and fill those gaps. And as Dave mentioned as well, we really have a lack of affordable housing in our community. We, on our most recent gap analysis, we are in need of over 2,400 units to fill the need of those experiencing homelessness in Anchorage. So that is something that we're working towards on as a community, is really kind of focusing like housing is the solution, and how can we get more affordable housing online?
Mm-hmm. Well, Dakota, that question leads into a question from, or your response leads into a question from Sam, who asked, with the FEMA COVID funding coming to an end, how did you secure funding for long-term programming? And is the hotel leased or is it city owned?
Great question. So the hotel was purchased by a group of philanthropic partners that created a nonprofit to be the title holder for the building. And so the building is privately owned and leased to us to provide services. One sort of piece that came into play maybe a year, 2 years ago is Anchorage started a tax on alcohol to help pay for homelessness services, a couple other things in there. And so currently we draw on some alcohol tax funds. There's the Alaska Mental Health Trust Authority that provides grants as well. And then we're also supported by some donation dollars. We have about a 3-year runway or 3 years of funding theoretically secured at this point. We still need to go out and do the applications and all of that. But the FEMA and COVID dollars were really the COVID dollars specifically were really used for the purchase of the building, some of those more large capital one-time type expenses. And then for operations, we're drawing from the alcohol tax, we're drawing from the Alaska Mental Health Trust Authority, a couple other smaller grants. And then we are, as an agency, we're starting to get into the 1115 waiver. And looking at potentially complex care as a place where we might be able to implement that. We're still kind of learning and just started getting those pieces going.
Thank you, David. That leads into some questions that I'm seeing as it relates to defining complex care. How do you differentiate with complex care? For example, do residents need to care for their ADLs? How do you define complex care?
So to directly answer that question, yes, clients do need to provide for their own ADLs. We understand that sometimes people have good days and bad days, which is why that staff do have a little bit of extra training on how to pick someone up safely, those types of things. But I think how we're defining complex care is still a community conversation. We, as the shelter operators, just sort of put one definition forward as sort of a working definition, and it's those individuals that meet that criteria that we have on that referral form, which include having some pre-existing conditions that are I can't remember the terminology, but as defined by I believe HUD for high risk. We're also, looking at people that have mobility or access challenges, so people that use a wheelchair, a walker, those types of things. I think that as a community, we're going to continue to sort of hone down in on what that definition is. As I mentioned, we've been operating for about 10 months or so, and there's going to be that good cycle of looking at what we're doing, how is it meeting the needs, what improvements do we need to make, how do we need to fine tune this. So I always see a program as kind of like a living, breathing, evolving organism, and we'll continue to be looking at those things as time moves on.
I think because there is so much around meeting those complex care needs and being able to differentiate when someone has complex care needs and when someone is looking for medical respite. Some of the questions in the Q&As is asking, how do you distinguish between the complex care shelter and medical respite? And I think from my perspective, and David and Dakota, I'd love to hear what your thoughts are on this. Medical respite is typically based on someone who was in a hospital setting or some healthcare setting, and they still need some time to recuperate. But that time is not necessarily care that requires being hospitalized. And so it's usually short term, like, a few weeks, probably no more than 30 or 60, just depending on the situation. But that's typically how I have heard of the difference between medical respite and the complex care, which is saying this person has these limitations, these complex care needs that are going to be ongoing. And it's more so about managing it for the long term as opposed to addressing an acute incident. So what are your thoughts?
Yeah, I would say it's exactly that. Medical respite, we have a sort of an upper limit of 60 days there. It's someone has a boo-boo that's going to get better, or they have a flare-up of a chronic condition that they need help managing, but they're going to get back to baseline. So more of an acute condition where there is a resolution to that. Where complex care, we're dealing with a lot more chronic type things that someone needs to get some support and learn how to manage long-term for the rest of their lives. And so really thinking of as medical respite as acute, and with a resolution in sight, and complex care more as more managing someone's condition.
I would co-sign both of our panelists here, and that is exactly our understanding as the COC, the difference between kind of complex care and medical respite. And to add, and kind of following up on the last question, with those who do struggle with their ADLs and IADLs, as Dave mentioned, there's some people that have their bad days and their good days, and there are some folks that really do struggle with their IADLs and AADLs. And so we have also, along with this kind of pop-up of this new shelter, have created a medically fragile case conferencing, where it's individuals that are staying at complex care, but also individuals that are staying at other shelters, that we created a pathway to apply for home and community-based waivers. So case managers are learning how to apply for a Medicaid waiver so that somebody can move into an assisted living facility. So that is, their safe and sustainable housing option. And that's where their need is an assisted living facility. And with the creation of the shelter, we had to be very careful with kind of that difference, because we didn't want to have to be licensed as an assisted living facility. So we kind of had to make that distinction, though understanding that that need is still there. And so we've kind of, with our case conferencing, we have experts at the table from our local Aging and Disability Resource Center that are really able to provide their expertise on each individual case and help them work through the process, because it can be quite long. In our state, it can take 4 to 6 months just to work through the process and get on Medicaid and get the waiver. So we're trying to fill the need and meet the gaps throughout our system, but understanding that there are still people with very high needs.
There's a question as it relates to stay. For example, when a resident no longer, maybe their complex care needs have been resolved, if you will, what happens to that individual? What housing strategies or exit strategies are put in place to help this individual move to permanent housing?
Yeah, so complex care is emergency shelter first and foremost. And so it is a housing focused program. And so the goal is to get someone connected to housing that they're going to be successful in, that they want to go to, and those types of things. So just like any other emergency shelter that has a focus in housing, our goal is going to be trying to move individuals into a more permanent type of housing situation. And so that's either going to be through coordinated entry or through, other housing opportunities that could present themselves within the community. There's a couple of housing programs that are coming online in this summer or, in the next year or so that will be hopefully referring a lot of people to. Definitely trying to move people towards housing with the supports that they're going to need to be successful in that. I also saw a couple of questions in the chat, around sort of rules and it being low barrier or those types of things. And again, this is it is emergency shelter. We consider it low barrier emergency shelter, understanding that low barrier and high barrier, it's not a binary thing, it's a continuum. So yes, it is not walk-up service and sort of referral based program, but a lot of our philosophies are low barrier. So a couple of people specifically asked about like mental health and alcohol and those types of things. And de-escalation. All of our shelter staff, they go through the same type of training that they would go through at any other, at some of our, at say Brother Francis Shelter, our walk-in emergency shelter. So de-escalation training, mental health, first aid, all of those types of things. And it has a lot of the similar rules that we would have at our regular shelters. So we don't allow people to have substances or use on site or in the facility. But if someone arrives, from wherever they were during the day and they are intoxicated, as long as they're not a danger to themselves or others, they'd still be able to, use the facility. We have, staff that get that type of training, to be able to sort of de-escalate and provide safety, and trying to keep it as low barrier as possible. Our goal as shelter providers is to keep people in shelter, not to kick them out.
To add to that as well, when we were kind of developing the concept of the shelter, we understood that while, an emergency shelter, the goal is for somebody to stay a pretty short period of time, sometimes less than a week. But we understood that with this shelter and this population, we estimated that the length of stay was going to be a lot longer, around 6 months. And as Dave mentioned, with that goal of people exiting the shelter into housing, because we've got these specialized case management and they're being connected with the care that they need. So the goal when somebody exits the shelter is housing.
Yeah, absolutely.
So it seems like a lot of questions are centered around knowing that someone has limitations in their activities of daily living. I think, Dakota, you mentioned about looking at home and community-based waiver services, but who is providing those services for the individual? Is that done for example, through a shelter staff person who has been trained in providing personal care? Is someone coming in from a home health agency? How is that occurring in the shelter?
So I think if I understand the question, that is, as a by and large, as a rule, that is not happening at complex care. We are not an assisted living facility, and so people really need to be able to do their ADLs independently of assistance to be able to access shelter. If someone is at a place where they're not able to do that, then they really require a higher level of care, and that's going to be something like an assisted living facility or a nursing home or something like that, which we are not. That being said, our staff do, as I mentioned, get a little bit more training than our regular shelter staff as far as how to do lifts and those types of things, that if someone has an emergency or an accident, that's sort of a once in a while type thing, that we're able to safely pick them up and say, put them back into their bed or their wheelchair, or help support someone that might be a little bit wobbly. But as a rule, we are not assisted living. We don't provide that service. We're not licensed for that. We don't have that high level of medical training. But historically in Anchorage, most of our shelters have been congregate shelters. And we are finding that a lot of people that might need a little bit more help, they can still provide for their daily needs pretty much independently, but they were not doing well in a large, low barrier congregate type of shelter. And so creating a specialized place for that, we thought was important to better fit the needs of those individuals. For example, like at Brother Francis Shelter for years, our mats, we had a proportion of people that were in bunks, but a lot of our, say, night by night emergency people would sleep on mats on the ground. And for someone that or even at, say, the Sullivan Arena, those cots are very, very low to the ground. At complex care, our beds are at a height to where it's much easier for, say, someone in a wheelchair to be able to transfer in and out of it. And so thinking about some of those operational things to just make the space a little bit easier for someone to be able to get around, as opposed to a large sort of one size fits all emergency congregate shelter.
Mm-hmm. And
we've really recognized in our community that is a gap for those who do struggle with their ADLs and IADLs. And as I mentioned, we have our case conferencing, and a lot of it is case managers really, really trying their best with somebody in the space that they're in. And we have outreach staff that are very kind and compassionate to folks and really trying to get them connected to assisted living facilities and even in hospitals so they can enter skilled nursing facilities. We are working towards, as a community, what it could look like for personal care services to go into a shelter, something that we're hoping to pilot soon. And because it can, that is somebody's home, that is where they are staying. We have some experience with a local clinic going into our mass care shelters and providing services and billing it as for Medicaid as a home visit, because that is where somebody's home is, that is where they're staying. So we're still learning a lot. As Dave mentioned, our programs are living beings that we continuously try to improve and look for outcomes, but also transferable learning as we're learning as a community. How can we share with others? Because we're only as great as our smallest community. So we can all get strong together and make sure that everybody has better outcomes and a better future.
Thank you both for sharing. I think a lot of the questions center around how do you provide these services? How are these services financed? And some of the points that you shared, David and Dakota, related to the criteria for or the definition of personal care, talking about what it means to provide home and community-based waiver services, and whether a shelter under Medicaid regulations would be considered an institutional setting or a residential setting. Those are the questions that would, I think, apply in this case. And then someone else asked about, mental health status, or someone who is experiencing some type of cognitive decline. what that impact is, especially David, when you mentioned that you have staff who may check around the site for someone who may have wandered off. So a question would be, is there like a secure entry and exits to the shelter such that it would not be an alarm would alert staff that someone has exited the building, etc. Do you have anything like that in place?
So I'll try and touch on all those points, but we do have a secure entry, and the facility is staffed 24 hours a day. We have staff on each floor 24 hours a day. We don't have security staff, but our guest services staff, are trained in a lot of those protocols. We find that as soon as, you have someone with a yellow shirt that says security on it, that interaction is just forever changed just by those roles. And so the people that are doing rounds through the building, checking on people, and they're doing our outdoor rounds, those are all of our guest services staff, that their first priority is meeting the needs of the guests and building a relationship with that individual. We find that all of our success and our client success is often built off of a one-to-one relationship that they've built with an individual there. That being said, those staff also have some security responsibilities, making sure and checking doors are locked and monitoring the area and those types of things. We don't lock people in, obviously, and so if someone were to walk out of say an emergency exit or something like that, an alarm would go off, but our staff would also be able to see that on camera. We have, there's security cameras and hopefully be able to catch that during rounds if it's sort of in a normal thing. We do have people come and go pretty much all day, as residents are coming into shelter or people are leaving to go throughout their day, and so there is a lot of inflow and outflow just sort of at that front door, but that area is always staffed by a staff member, and it's a secure door, so someone needs to be let in and let out. There is a couple of other questions. Yolanda, could you memory?
Well, I think you answered about the alert piece and the one question. So I'm going to move on because I'm watching the time. I want to make sure I get to at least answer some of these questions that might be a little different, David. One asked, would you be willing to share your referral parameters?
Sure. Yeah. Would I just send that to you?
Yeah, we can when we post the webinar, we can include some documents that maybe highlight like your referral, or there's been some questions as it relates to the prioritization. Like I think you mentioned you have 8 points. And so I think people are looking at something tangible that they could say, okay, this is what equates to 4 points, or whatever criteria is used in those points.
So I could speak to that. There's depending on how someone answers the questions in the referral form, they're going to either gain points or not gain a point. One of those is going to be a high priority pre-existing medical conditions that there's a list of them, but it's not limited to chronic lung disease, moderate to severe asthma, a serious heart condition, condition that causes a person to be immunocompromised, severe obesity, diabetes, chronic kidney disease or undergoing dialysis, dementia or other neurological condition, liver disease. There's a list of conditions that have been identified by, I can't remember if it was HUD or USICH as sort of high risk for people experiencing homelessness. If they also have an additional medical condition that put them at risk for COVID-19, that would add another point. If they had mobility related issues, that would add points too. If someone was unsheltered, so if they were staying in shelter or in a more stable situation as opposed to being unsheltered, that would add a point. If someone was pregnant, that would add a point. And then if it's someone is over 60, I believe that would add a point too. This is, I'll be the first to say that this is a pretty rudimentary tool that we're using. We just sort of had to get something up for, just sort of in the short time horizon we had to get the program up and running. Now that we have collected some data, we're everything that we do is getting entered into our data system and then entered into our community data system as well. We're at a point where it's probably going to be good, a year into the program to look at this referral tool and are there some changes that we need to make? Are there some tweaks we need to make? Is there a group that is being overrepresented or underrepresented? Does it have equity, baked into it? Are there, other pieces?
I think those are all good, very good points, David, when you mention about equity and especially as it relates to racial equity. And I think maybe Dakota, you mentioned a good bit in your presentation about how do you prioritize and making sure that there is equity in the provision of the services. One of the things that there are some questions around individuals who have some, I'm assuming, diagnosed mental illness, and how do you handle those types of situations? And I guess this speaks to de-escalation techniques or referrals that you may make or using crisis intervention teams within behavioral health systems. Like what is generally the policy as it relates to addressing an individual who's having some type of mental health episode?
So, I'll go back to, everyone at Complex Care goes through similar training that they would go through at a low barrier emergency shelter like Brother Francis Shelter. And a lot of that is going to include that de-escalation, mental health, first aid, safe talk, those types of things, that sort of lay a foundation and give you shared vocabulary to sort of talk about the things that you're doing and the things that you're seeing. But I think our primary tool that we use, at least within the shelter, is going to be building that relationship with that individual. Oftentimes, if someone does have mental health challenges or those types of things, if we're able to build a relationship with somebody and identify patterns and triggers and successful de-escalation techniques and like those types of things, those are really going to serve us best moving forward. And it's really building that relationship with someone while they're not in crisis, when they have their needs met, when they have a full belly and they've had a good night's sleep and have those, pieces, have that stability that, a place like Complex Care is able to sort of help with building that relationship. So then when somebody is in crisis, there's a trusted person or someone that they know that's coming to assist them, and someone that might have a little bit of experience with that individual. We do things like behavior plans and stuff with people. We have our list of sort of behavioral expectations. We try to keep it as simple as possible. I think there's like 5 or 6 things on there that are just about being safe, treating each other with dignity and respect, and like those types of things, rather than having a very, very long list of sort of consequences. And so we try to make those expectations of the program as easy to understand as possible, go over those with everybody upon intake, so people don't just sort of walk into the shelter when they come in. Like there's a sit down with with at least one staff member, oftentimes multiple staff members. And then if we are identifying issues, really being active as staff there, and not being sort of passive staff, but trying to actively build those relationships with people, and try to address the situations with curiosity and with compassion, but try to address those when it's like a little spark before it gets into a big giant sort of outburst, or it's a potentially intense situation.
As a community as well, we have kind of like a non-emergency 311 line we can call, and our Anchorage Fire Department has a mobile crisis team. It's a team of 2 individuals who are not police officers, and they are trained in behavioral health. I think one is even a behavioral health clinician, and they will do an assessment and connect somebody to the resources that we do have for behavioral health, which is, we will say is another gap in our community, but we do try to fill those gaps as they come and as we see them, and really try to connect people with what they need the most.
Well, this has been a very engaging conversation, and I wish that we had time to answer more of the questions that I see in the chat. I think this just points to the fact that there's a lot to garner from people who have started to implement these types of programs, making distinctions between a complex care shelter and medical respite, and looking at financing options and training options and protocols as it relates to the implementation or delivery of services in a complex care shelter. I would ask that those who are part of the audience, if you have some, I want to say some other questions or some things that you would like the Alliance to present or share as it relates to older adults and healthcare issues, please look at the chat and send me an email so that this can help to inform the work that we are doing, especially for those individuals who are living with some type of disability, mobility issues, cognitive decline, those sorts of issues, and older adults in general. So thank you again to David and Dakota. Thank you to all of you for participating in the webinar. Again, we will have the slides posted by the end of the week, and we'll include, as David agreed to share, a little bit about the referral form, noting that it is in development and they're practicing its use as we speak. So thanks, everyone. Have a good rest of your day.